the April 26th, 2022 meeting of the Joint Commerce Committee of ZSFG. And I want to extend special thanks to Commissioner Chung for attending. As you know, Commissioner Chow is out today, and so we really appreciate your coming along and working with us. So with that in mind, should we call the meeting to order and then call the roll?
Commissioner Green.
Present.
Commissioner Chung.
Present.
Thank you. I will read the land acknowledgement before we move on. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who were the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land, and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples. We can move on to item 2, which is the approval of the March 22nd JCC minutes.
All right, so absent any corrections or additions, is there a motion to approve the minutes?
Yes, motion to approve the minutes.
And I will second that. And then is there any public comment?
Thank you for asking. Person on the line, if you'd like to make comment on item 2, the minutes of the March 22nd, 2022 meeting, please press *3 now. *3. I see no hand.
All right. So shall we vote to approve?
Yes. Commissioner Green.
Yes.
And Commissioner Chung.
Yes.
Great, thank you. The item passes. We can move on to item 3, the regulatory affairs report.
Good afternoon, everyone. Hello, commissioners. So section 1 pending surveys, they remain the same. We anticipate our Joint Commission lab survey and CMS surveys for our long-term care SNF for recertification, fire life safety, and our dialysis recertification. Completed surveys, we had our DHCS annual state inspection for OTOP. We do anticipate one deficiency, which I'll go into later on. And we had 4 cases that were closed with no deficiencies. Plans of correction, there are none for this report out. Open on-site visits, so current activity, wrong site surgery, item 7. We got a verbal exit. It was substantiated with deficiencies. It's pending approval by the supervisor, so when we receive it, we'll formulate a plan of correction. Item 16, fall with injury on 4A, documents were requested, and actually they're setting up interviews with involved stakeholders. Item 23, medication error from the ICU. We had a surveyor on site, pharmacy consultant on 4/14, and we've not heard any follow-up yet from that visit. And lastly, item number 44, a retained Penrose drain from surgery in May 2020. Documents have been requested, and also a request to set up interviews with stakeholders for that case. Section 5, new facility reported incidents. We had 2 privacy breaches, one regarding unauthorized access and one regarding mishandled PHI. 2 cases of sexual assaults, 1 elopement, 2 Joint Commission complaints, one regarding allegations surrounding unsafe working conditions due to a broken dumbwaiter in SPD. The dumbwaiter just transports instruments from SPD up 1 floor to the OR. And the second complaint alleges that an RN did not check blood sugars, resulting in a patient having hypoglycemic seizures after insulin administration. And lastly, there was a fall. A patient was admitted with a subdural bleed. However, there was an unwitnessed fall, and imaging indicated that the bleed was larger. Next section, state annual licensing survey for OTOP. We're still pending the official written report. Prelim findings involve 1 minor finding regarding the multiple registration form. There was a box for alias, a box for distinguished marks, and a box for NA. The inspector stated they wanted an NA box for alias and a separate NA box for distinguished marks. So that's been taken care of by OTOP. There's one possible finding, the decision still pending regarding waiving observed dosing due to COVID-19 and social distancing. We've not heard back about the final decision for that. The last section, plan of correction monitoring data. We had a finding regarding documentation of interpreter use. We're still working towards reaching our target of greater than 90% compliance. And then the last one is PCP notification process upon admission. I'm happy to say that they've completed monitoring and met their target of greater than 90% compliance for 3 consecutive months. And I can help with any questions, just review.
Thank you so much. Is there any public comment on the item?
First on the line, if you'd like to make comment on item 3, the regulatory affairs report, please press *3 now so we can recognize you. *3. I do not see a hand, commissioners.
Great. Any questions or comments, Commissioner Chung? Anything? Oh, you're on mute.
Not at this point. Thank you, Commissioner Green.
Well, I think it's quite remarkable the work you've done with PCP notification. That is one of the biggest kind of problems and bottlenecks in the system. And I suspect you're doing better than many other institutions in being able to do that and reach out. So I think that's really quite remarkable. And it sounds like most of what we've got on the SIS we've either reviewed in the past or we're just pending more information, that nothing here sounds terribly worrisome. So anything else or? I thank you so much. I think this is wonderful report, very much appreciated.
Thank you.
So I guess we can go on to the next agenda item, which is a quality strategic improvement plan.
Dr. Day.
Good evening, Commissioners Green and Chow. Can you can you see the slides or no?
Not yet,
Not yet.
but I like your orange shirt.
Thank you.
Dr. Day, it's the button at the bottom that says share video.
Yeah, sorry about that. Guys,
Not yet. There we go. We're seeing your screen, but not the, there we go. We see the slides now.
So thank you again, Commissioners, for your attention and the opportunity to present tonight. I'm going to share with you an update on the quality work that we have been doing over at ZSFG. A couple of months ago, Terry and I presented our initial quality work, really giving you an overview of how we thought about quality for the past year at ZSFG, especially in light of COVID-19. Tonight's presentation is really just going to be an update on this work and really to give you a sense of where we're thinking about moving for this particular year and probably in the next 2 to 3 years as well. So one of the things you can see is that we've changed our topic, or at least our title, which is Unifying and Leveraging Quality Work Across the ZSFG Campus. We changed this title for several reasons, but I really want to draw your attention to sort of 3 of the words here in our title. The first is unifying. So one of our goals with our quality work is we wanted to bring together all of the work here on campus in one unified, clear, consistent message. So really trying to sort of solidify it and sort of narrow that focus down. Second is leveraging. So leveraging really, at its core means taking what you currently have and using it to accomplish something, but really how you maximize or optimize something. And so really trying to think about how has the work over the past year informed things that we're going to be doing in the future, and how do we leverage and maximize that work. And then again, what stayed in the topic title is the ZSFG campus, really being thoughtful that we include all of our operational areas, or at least a majority of them on our campus, knowing that many areas are represented. Acute care settings such as emergency room, urgent care, inpatient setting, procedural or outpatient clinics. So just to level set, we always like to start with our True North pyramid. To sort of orient you to this, at the top of the pyramid, we have sort of what I like to call the who. So who are we doing all of our work for? Really all of our performance improvement work. Why are we doing this? Who is it directed towards? And at the top of it, it's our patient and our community. And so that's really what most of our quality work is going to be focused on. How do we improve the lives and the health of our patients and community that come to the ZSFG campus? Next at the middle is sort of the where. I like to think of it as where would we like to go? What are we trying to aspire to be? And that really is embodied in our vision and our mission statements. And then at the bottom, which I like to sort of think of as the foundation of the pyramid, really which supports all of this work and where we want to go, is the how. How do we accomplish all of this? And at the very bottom, you can see our True North goals. So these are bucketed into 6 key priority areas. And so for tonight's presentation, we're going to focus on the quality True North pillar. So when we came to you several months ago, we shared with you our A3, which was developed at our 2021 Ocean event. The A3 here is broken really into 2 sides. On the left-hand side, we went over really our background, trying to understand where we currently were, look at our current conditions, develop a problem statement at that time directed towards how we would improve quality on our campus, really focusing on flow and access. We then identified some key metrics or key performance indicators. And then we did an analysis of how we were going to be able to accomplish all of these metrics and be able to meet our targets. On the right-hand side, it was really our countermeasures. So what we were going to implement to try to be successful in achieving all of our metrics, and then really our project plan for that year. What I'd like to do tonight is revisit this A3 a little bit and really walk you through some of these key areas again, but really with a little bit of a different approach to it, really providing some updates based on what we've learned over the last year, really taking into account COVID-19. And in fact, we had 2 of the largest surges over the past year. And so how this informs some of our work. And so really how we're thinking about this for the next several years. So by way of background, much of this hasn't changed since we last presented our A3. There were 4 things that we highlighted last time that I think are still relevant today. The first is healthcare quality falls into many domains that we know, includes effectiveness, efficiency, equity, patient-centeredness, safety, and timeliness. And much of all this really, I think, helps drive the quality work that we do. We do know from our past that ZSFG's quality work in many cases has been fragmented and siloed. I would argue that it's also been incredibly high quality work and impactful work and innovative work, but in many cases, it may be done in parallel to other groups. Historically, our quality improvement work and indicators have focused mostly on the inpatient setting. And so one of our goals, as I said, is really trying to unify many of our operational areas here on campus. And then finally, which I still think is important in today's climate, is that the COVID-19 pandemic turned much of ZSFG's attention and our operational readiness to other areas and really focusing a little bit less on quality and some of our other key pillars. And so one of our goals, and continues to be one of our goals, is how do we sort of, live with COVID-19, but really ensure that we're moving forward in other areas of our quality improvement work. So our current conditions. So this was the slide that I showed last time when I went over our current conditions, which is a really busy slide, but I think it tells a very nice story of how healthcare, especially at some of our campuses across the country, are organized. There are many aspects to it. As I had mentioned earlier, there are acute care hospitals, which is driven mostly by our inpatient and emergent settings. There are outpatient clinics, such as our specialty care clinics, our diagnostic services, our procedural-based clinics, our perioperative areas. There are many facets that create sort of our overall operational campus on here that delivers healthcare to our patients and to our overall community. So our goal last time was, how do we unify all of this? What we developed were 5 key metrics or 5 key priority operational areas that we wanted to focus on. They included our urgent or emergent area. And so we chose 1 metric there, which was our ambulance diversion rate. Moving over, our JCC, which is our care coordination department, we focused on lower level of care days for inpatients. We then moved to the outpatient setting, which is our specialty care clinics, focusing really on wait time for new patient appointments. We then did our med-surg critical care, which is our inpatient area, looking at bed turnaround time or bed cleaning time. Really, when is a bed available for a patient down in the emergency room, available for that patient to come up and take that bed. And then our perioperative area, really looking at OR block utilization. So previously, these were our 5 key performance indicators or metrics that we were focusing on in 2021. Well, how did we do? So this table here, and I realize there's a lot of data on here, so I'll try to walk through it a little bit. But on the left-hand side, we have our operational areas that I just identified to you on the previous slide with the metrics associated with them. The other two columns is really what was our calendar year or our 2021 ending or overall value, and what was our target for that year. So within the emergency department, as I said, we were focusing on ambulance diversion. Our goal was to be under 40%, and you can see here that we didn't really reach that target. We were at an overall 50%. But the one thing I do want to highlight is that we actually trended down. So when we started this work, our ambulance diversion rate was over 60% from 2020. So while we didn't reach our target here, we actually did show some significant improvement and definitely were trending in the right direction. For our bed cleaning request turnaround time, again, we were off target for the year. We didn't meet our 1 hour metric. However, we made, I think, probably our most dramatic improvement in this area. We went from about 85 minutes down to about 76 minutes. So again, trending in the right direction throughout the year. Our Department of Care coordination, so we were on target for this, and this was the only one that we were on target for the majority of the year. And again, we met our target of being under 950 days, and we continued again to trend green in this area by trending downward. Our perioperative and procedural areas, this was looking at surgical services that had an OR block utilization of over 80%. As you can see here, we were off target again, but I do want to really highlight the work that was done in this area. We made tremendous improvement really in a short period of time. So when we started this work, our OR block utilization was at about 52, 53%. And you can see we made significant improvements through several directed countermeasures, getting that close to almost our 80%. And then finally, our TNNA, or our wait time for our outpatient clinics. So this is the proportion of all clinics that have a wait time under 21 days for new patient appointments. Again, we were off target here. And unfortunately, we actually trended in the wrong direction in this area. So we started off around 84, 85% of our clinics meeting that 21-day target. And unfortunately, this dropped over the past year, which we think is more likely due to, one, staffing shortages, but also two, clinic closures due to two of the largest COVID-19 surges, the Delta and the Omicron. So as we took a step back in thinking about our quality work, we really wanted to think about how do we tie together our True North metrics or our True North key performance indicators with our overall True North outcome. And again, that goes back to really unifying and leveraging our quality work, really trying to bring those two key aspects to the forefront in our work. So again, I apologize for this slide. This is our ZSFG X matrix, which I think all of you have seen before. But again, just to orient you to it, really right along here where my cursor is as I'm moving across. Again, those are our 6 pillars as part of our True North pyramid. And these are the metrics below each of those that we have developed, or the key performance indicators that we have developed to help support those True North metrics. Over here, we have our True North outcomes, which is a single outcome that should span many of those True North areas or those True North pillars that ultimately we're hopefully trying to accomplish as our overall outcome or our overall goal. And so what we wanted to do is really, how do we tie together the quality we are doing, our 5 quality improvement True North metrics, or our key KPIs, how do we tie that to some of our True North outcomes? So if you kind of follow my arrows here, if you go down, we look at our quality, it goes down to our True North outcome. And you can see there's really one True North outcome that is associated with our quality pillar, which is our star rating, or our CMS star rating. So a little bit of background on the CMS star rating system. I think you've seen several presentations on this. This was a system developed by CMS several years ago, where they use a very robust and detailed methodology on several key quality indicators to come up with a rating system for hospitals across the United States. It's supposed to be objective, non-biased, and transparent. And it's supposed to give providers, healthcare systems, payers, and patients sort of a way to judge the performance, at least based on quality, of healthcare systems and entities across the country. And so again, this quality rating system is our True North outcome that is very much tied to our quality improvement work. So with all that in mind, we decided we had to revisit our problem statement and revise it as I've illustrated here. And so to walk you through it, our problem statement is divided into two sections. So while ZSFG remains engaged in battling the COVID-19 pandemic and is likely to do so for the next several years, we must continue its true north goal of improving access, patient flow, efficiency, and quality of care for our patients. However, while significant improvements were achieved in our ZSFG quality KPIs during 2021, our 2021 targets were not achieved, as I showed earlier. Some of our operational areas were not included in this improvement work, and it is unclear if this work actually would advance our goal of reaching a higher CMS star rating, our overall outcome. So with this in mind, so realizing that our access and flow targets were not achieved, we may not have included all of our operational areas, and really trying to understand how this work advances our goal of achieving a higher CMS star rating, we took that into mind and really revised the work that we were going to do for the next several years. So again, I want to frame what is the CMS star rating, that there are many components to it. There are 5 key areas that look at quality in these spheres. There's mortality, safety of care, readmission, patient experience, and timely and effective care. And it comes down to really 53 different quality measures that are looked at through a very rigorous methodology and a rating system. So we wanted to understand, how is ZSFG doing? So at current, we're at a 1 star. And so we wanted to look at, of all those 53 different quality measures that are assessed by CMS, what were the areas that ZSFG scored the lowest on and actually were driving our lowest score as well. We thought if we knew what these specific quality areas were, this could inform how we wanted to develop and drive our quality improvement work, again, for the next several years. So here are the top 10 quality areas that ZSFG scores the lowest on, or is in the lowest percentile in the country, that really drives our CMS star rating to date. So in looking at this, we then took another deeper dive and sort of asked ourselves, well, do any of the KPIs or those metrics that we developed last year, do any of them really drive some of these, and could they inform some of the work that we do? And so we saw some that did, and actually these fell into really 2 key buckets: the emergency department and our perioperative area. So the first is patients who left the emergency department without being seen. And so we know that a lot of our quality improvement work around the ED focuses on this. And so we thought that continuing with our ambulance diversion rate, that much of that quality improvement work around that actually also helps inform some of this work here. So we decided that we would continue to keep that metric on. The next is our 7-day standardized risk rate after outpatient colonoscopy. So that falls into that procedural or surgical based sphere, so our perioperative area. While OR block utilization doesn't really drive this metric, we thought a little bit more about how do we potentially improve some of our discharge processes within the perioperative space. And so we're continuing to work on that and doing some deeper dives into this specific area to ensure that our discharge instructions that are provided to patients after their procedures are clear, and that also patients have a mechanism in place to contact providers or at least staff to answer questions after their procedures. The other is time in the ED after being admitted before arriving in their patient room. And again, we still felt that our med surge or our critical care metric around bed cleaning turning time really drove this. And so we decided we would actually continue to keep that metric. And then finally, hospital visits after outpatient surgery. Again, very much within our perioperative and procedural area. Again, really looking at our discharge process there. So we overall felt that many of our current of those 5 metrics or those 5 KPIs that we had identified before were still relevant. They still drive a lot of this work here. They still help improve flow and access on our campus. And many of them will still continue to drive, we think, our CMS star rating work. So based on this information, we then developed our countermeasure summary, which we highlight here. It falls really into 5 themes. The first is staffing, and this really focuses on ED and med surg staffing. We know that when we saw positive trends in many of our metrics around quality improvement, it really was when we were fully staffed. So much of our priority moving into this year is going to be ensuring that we are fully staffed in several of our areas across the campus. The next is standardizing our processes really around our patient room cleaning turnaround time, but also potentially looking at things such as our discharge processing, such as in the perioperative and procedural areas. COVID still definitely played a major role throughout the last year. As I said before, we had several surges and some of our largest surges during that time, which resulted in many of our outpatient areas being closed. So we revised our surge plans to really ensure that we minimized future closures in some of our outpatient areas, knowing that this has a significant impact on access and flow and quality. We have a backlog of patients that still need to be seen due to the delay in care from closures from our COVID-19 surges, and so continuing to work on that. And then also really trying to increase capacity within the med-surg space, really trying to optimize the opening up of our H58 unit to help with flow and access on the campus. So our next steps, so we still are continuing to meet with our stakeholders to solicit input on our previous quality key performance indicators. We will likely continue to refine them and update them as needed. Additionally, we also want to make sure that the work that we're doing is aligned with the work throughout San Francisco, specifically within the Department of Public Health and the San Francisco Health Network around their quality improvement work. And so their potions are currently ongoing, and quality is a pillar in each of their areas as well. So we want to ensure that the work that we're doing, that our quality metrics and that our KPIs are aligned with theirs. We also want to ensure that we include other operational areas here on campus. So 2 areas that we're currently looking at and trying to align some of our work are within psychiatry. So looking at some of our inpatient psychiatry metrics to see if there are ways and areas we can improve flow there. And also within our diagnostic areas, specifically within radiology. And then finally, within the next couple of months, we will participate and complete the ZSFG potion for this year, where we will finalize all of our KPIs and eventually our outcome. And then we'll bring that back to you in the next several months for your input and feedback on it. And with that, I'm happy to take any questions, comment, or feedback.
Thank you so much. This was a really thoughtful and excellently detailed presentation. I really appreciate it. Is there any public comment, Secretary Morowitz?
Folks on the line, if you'd like to make comment on item 4, please press *3 now so we can recognize you. Again, *3. No hands, commissioners.
All right, I see Commissioner Chung's hand up.
Yes, thank you for the presentation. So the first is the feedback that the materials that were sent to us was very difficult to read. You know, I was hoping that the resolutions, it might be a resolutions issues, and and the slides that we will see today would address that issue, but it didn't. I found my eyes really strained, trying to like make sense of the first chart, the A3, and also the other ones, which is the star rating, like matrix. So that's just the feedback. And the second question I have is, it's great to see that a lot of the indicators are moving in the right directions. It's just a question about process. Do you do all these indicators at the end of the year, or do you do them quarterly so that you have a way, like to really look at what needs to be changed, in the intermediary sessions, so that it will move toward the directions that you desire?
Yeah, no, thank you very much, Commissioner Chung. So I appreciate the feedback and sorry about the resolution on some of the slides. We can definitely send you larger versions of the X matrix as well as our A3. Unfortunately, it's a lot of information crammed to a very tiny space, so I apologize for that. In regards to your question, so for each of the 5 True North metrics or KPIs that we follow, we actually follow all of the data on those. Several of them we follow on a daily basis and then some on a weekly basis. The way we report out for ours is that if each one of them is green or not. So of the 5, how many are green? And our goal is 4 of the 5. And we track that on a monthly basis. And so the data that I showed you was an overall average of the year for each of those areas. Overall, across the year, what was the mean or the average number for each of those. So just to give you kind of a sense in terms of where we finished after all of our work.
So because of your response, I actually have another question. Is there actually some analysis around which period of time when these indicators were more off the mark, so that maybe we as commissioners, because we don't follow the daily operations, so that we can be more informed, like and trying to like make some like associations with like what kind of events are happening during the time, like the COVID spikes, for instance.
Yeah, no, that's a very astute question. We did do that analysis, and what we found is that where we were significantly off target or trended in the wrong direction was usually in the weeks before, during, and a few weeks after the two largest surges. So during the Delta surge in January of last year, but that continued into February. So we were off target pretty significantly and trended in the wrong directions during that time. However, once we hit March, once we started reopening, we actually were able to see trends in the right direction. We may have been off target, but we saw definitely a trend in the right direction. And then again, once the summer hit, and then also again at the end of the year with the other surges, we also saw that we started trending in the wrong direction again as well. And two things we think really drove that was, one, we closed down many of our outpatient services during that time. Our ambulatory care clinics and our perioperative and procedural areas reduced services. And then also that's when we started seeing significant staffing shortages. Those significantly impacted a lot of our metrics. And we are still recovering from that, but we still continue to struggle with those.
Well, thank you for your diligence, and also, thank you for your answers to my questions. I think that for lack of a crystal ball to look in the future, like those are like some of the issues that is understandable, and I think that, that needs to be somewhere, reflected as well.
Absolutely, thank you.
Thank you. Those were really great questions. I wondered, there are a few things on here that I don't think we need to do in this forum, but it'd be really great to get a little more detail about, for example, what 7-day standardized risk rate really means. There were things on here that I wasn't sure, but I have two questions, I guess, and I think they come together. One is, do you think in light of the staffing issues that the goals were actually set too high for some of these areas? Given that none of us could predict what was going to happen with COVID, especially the huge number of people that were out, which I think was completely unanticipated. And then secondarily is, the star rating has just been such a kind of a thorn in our side. And I'm wondering whether any of these items are more heavily weighted as we look at ratings, and also, how you're deciding to prioritize items that really, would impact the star rating versus items that we know need to be fixed from a pure operational perspective. How are you thinking about those things and kind of meshing them together? How are you unifying them? I might ask.
So to answer the first part of your question, I do believe that we were a little ambitious with the targets that we set for each of the KPIs. One, I think when Terry and I sort of took a step back and looked at it, I think we wanted to push each of our operational areas to really strive to do the best that they could. And I think we try to use data that we had in the literature in each of those areas of where we should be. Also, when we developed it, it was really around the time of optimism. It was right before COVID-19 vaccinations were released. And so I think at that time, we were optimistic that 2021 would be a little bit different than it turned out to be. That there wouldn't be as many surges as there were, and that while we did see some staffing shortages at the time, that we wouldn't see them to the degree that we saw in 2021. I still think they're the right targets. I don't think I would change the targets because I think they're really consistent with best practices out there. And ultimately, I think will really improve the care of our patients and really, I think, solidify that we are a high quality organization. The second question is a much more complicated one that I think we're going to address during our potion, which is around the CMS star rating. We've debated this among our executive team quite a bit about, should we keep that outcome on there, especially when the data is retrospective and many years behind, and so it may not necessarily reflect some of our quality improvement work. I might turn to others on the call to get their thoughts on this, but this is one of the things we're going to be addressing in the next few weeks, is really, should we continue to keep that outcome on there? And if we do, how do we best leverage our current work to make sure it's reflected in it?
Yeah, I'd like to comment on that actually. This has been a very hot topic of debate since I've been here, and we've been doing our Hoshians a number of times. I think the truth is, we know that the star rating is skewed against us. When you look at star ratings, for example, among public hospitals and safety net hospitals versus all hospitals, there's definitely a skew to the left. So public and safety net hospitals are more likely to be 1, 2, and 3-star hospitals as opposed to higher. And there's been a lot of advocacy work around addressing that. The main issue is that, we are, as you well know, we are really impacted by social determinant of health factors that impact things like, readmission rates, for example, or stays, length of time that patients stay in the emergency department. So we know this rating isn't perfect for us. At the same time, it is a very clear rating. It is one that is well known, and it does contain work that is really relevant for us. And I think the key is contained in what you raised, Commissioner Green, about aligning the work that we do with the star rating and being operationally important for us. So I think in the end, even though it's been an imperfect True North metric, we've elected to keep it for a variety of reasons.
Thank you. This is just incredibly thoughtful protocols and ideas and plans. And when will we hear about the outcome of the Hoshin when you kind of conclude your discussions? When would that come to the JCC?
So we are constantly revising our plans depending on the external environment. We had hoped that we would have very clear direction at this time from the department and the network, so that we could incorporate their Hoshians into ours. That work has been slower going than we thought for a couple of big reasons. And so we're modifying our plans. We're going to have a Hoshin that is more like the one that we had last time, where it is kind of slower over time. So I think by the end of the summer, we should have a really good sense of it. We may come to you sooner than that, but over the next few months, I think is a good target for us. And in the meantime, we'll keep working on what we're working on now. I just want to say, I think it's really, I'm so grateful to Dr. Day and the other leaders of the executive team and others in the hospital who have been completely devoted to doing data-driven improvement and continuing to use principle-based leadership while we have crises of all kinds going on around us at all times. It really says a lot about the integrity of people working in this organization that they're devoted to doing that.
Thank you. Thank you so much. And again, thank you for this really thoughtful presentation. So I guess we move on to the Chief Executive Officer's report and Emergency Department newsletter.
Actually, before we do, Commissioner, if you're okay, I wanted to read a comment Dr. Marks wrote in the comments just so that we hear it. I'll read it verbatim. We bring our True North scorecards to JCC, I believe, quarterly. This has been monthly as well as year-to-date performance for each of our KPIs as well as our True North outcomes. And that, I think, is more for Commissioner Chung, who didn't know that information. All right. And now to you, Dr. Ehrlich.
Okay, back to me. Good afternoon. I'm Dr. Ehrlich. I have the privilege of being the CEO at ZSFG now for 6 years. I just passed my 6-year anniversary. Commissioner Chung, thank you for joining us this afternoon. So I wanted to say a couple of things that are top of mind right now for us before I go into narrating the report I sent. And one is, and mainly that is about the way that we're involved in the Laguna Honda effort. So first of all, our Chief Nursing Executive, Terry D'Antoni, is now the acting Chief Nursing Officer at Laguna Honda. and that was effective on Monday, and that's why she's not here. But we're really grateful that she's lending her expertise and experience to helping Laguna Honda with their recertification. We also, our Chief Communications Officer, Christine Falvey. She's new, and she's also lending her support, as is Adrian and other people as needed to ensure that Laguna Honda is successful in their efforts. I'll mention some of the committee work that we're also engaged in as I go through my report. So one thing to notice about the report to start is that the COVID section is very small compared to other reports that I've given you, and it just means that we are doing other things right now. There are still impacts on ZSFG of COVID, and I will highlight those as I go through the report. I did want to point out the work that we're doing in equity, particularly the work that Dr. Day drove around us being designated as a LGBTQ plus healthcare equality leader in 2022. We scored 100, which is the best score you can get. And you can read a lot about why and how we got that score. I think the part I'm most proud of is that it demonstrates that we're committed to improving the health and wellness of our LGBTQ plus community and providing world-class care with equity, compassion, and respect. So I really want to thank Dr. Day for his efforts to get us certified in this way, and very, very proud of that designation. I also wanted to talk a little bit about our annual employee celebration. This is such a delightful thing that we do. This year, we celebrated people, as we do, who have devoted their professional lives for 10 to 35 years. And if you add up the years of service of these folks who we celebrated, it's 3,350 years of combined service that people have devoted to the hospital, which is really tremendous. So I'm really grateful to the folks we were able to recognize. And in particular, every year we point out one DPH employee and one UCSF employee who are really exceptional. And I invite you to read about them. Cindy Ma, who's a senior hospital eligibility worker, and Wynn Bamberg, who supports the dean's office in really terrific ways. Okay, any questions about that before I go into the data?
I just think it's a testament to the culture you've created there and sustained there, that these individuals have worked for so long, and reading about them, how incredible their dedication is and all the contributions they've made. And we'll definitely report the LGBTQ honor to the commission at large when we give the report to the next commission meeting.
Thank you, Commissioner. And the beauty of this place is that these folks were here long before I was, and you know, the culture is very strong with or without me. And that's one of many things I really love about this place.
Yeah.
So if you look at the first graph, which shows our COVID positive patients, I love this graph because it's a very clear picture of the surges that we've been through here. And thankfully, we are not at any of the peaks or even close. Our COVID census today was exactly 1. We have 1 patient in our med-surg unit. And so the census has been low, particularly if you look at it, you know, related to the peak of the Omicron surge or the peak of the previous winter surge, which interestingly are almost exactly the same, even though the circumstances were quite a bit different. The next thing I'd like to move on to is the graphs of leave without being seen and diversion. We talked about those a little bit. That's a real focus of our quality work. And we have seen it come down a little. It's still well above what we would like to see. Right now, we know that that's mainly driven by staffing. We still have significant staffing outages for a variety of reasons. And we're working very hard to accommodate that. But what it means is that we end up closing beds that we can't staff. And so that's a big piece of what drives our diversion rate right now. We do have a plan, in addition to staffing, to making sure that we're doing everything we can to minimize our time on diversion and trauma override. This is a major issue for EMSA, our local EMSA, as well as other hospitals in the city and the ambulance services and the fire department. It's really a citywide effort to try to improve the pre-hospital care situation. So that is an ongoing, very focused piece of work for us. The transfers from urgent care to the ED, you asked some questions about that, Commissioner Green, and I sent you back a lot of detailed information about that. I think the bottom line, and I wanted to just call out 2 points about that. One is that the way that we display the data as average daily transfers kind of masks what's really happening, because over the weekend, the census in urgent care is quite a bit lower than it is during the week. So for example, yesterday, the urgent care clinic saw 135 people, but over the weekend, they would have seen 50. And granted, 135 is a very high day, but they're typically seeing about 600 transfers a month to the emergency department. And what was great about looking at the data in more detail is that it made it really clear that the urgent care clinic has been absolutely essential to pretty much now permanently reducing the least urgent patients from the emergency department. So those ESI level 4 and 5, which are the least, which are the lowest acuity patients, they went from 30% of the ED's volume down to 15%. So the urgent care clinic has had a major impact on helping the ED cope with its volumes of all types, and in particular during the time of this improvement, COVID patients, but really non-urgent patients of all types. So that's really exciting to see. The PES encounters and the daily admissions, this is no different than it's been for the last several months. I've reported to you, we just have real bottlenecks in on our acute psychiatric services because we have a hard time discharging to certain types of locations, particularly locked psychiatric units. So for example, today we had 16 patients on our acute psych service waiting for that level of care. Residential care facilities as well. It's less of an issue, but that was about 6 of the patients. So that's what drives that statistic. You also asked a question about the MCH average daily census. So I think you probably know this as well or better than any of us. There's been just an overall surge in births in the city, and we see that here. It is true that we have contracts for patients who are otherwise insured from San Francisco Health Plan. So we have a contract with Canopy, and we have a relatively new contract with the Health Plan of San Mateo. But that represents a very small number of patients. The other factor here that is interesting to note is that we have longer antepartum stays for some women because of their substance use issues, and working with them on buprenorphine or methadone, so that increases the length of stay as well. So it's a variety of different factors. I know you also wanted to talk about the lower level of care. We think a lot about this. It's definitely part of the quality work that Dr. Day described. It's a real issue for us, and you can see that in the numbers. It's particularly a concern right now because we rely on Laguna Honda to take about 4 new patients a week. And Laguna Honda, as you know, is not taking any new admissions, and it's going to be that way for quite some time, which we completely understand, and it has an impact on our operation. So for example, today we have 39 patients in our med-surg unit only who are waiting for a lower level of care. 19 of those were skilled nursing discharges. Not anywhere near all of them would be waiting for a Laguna Honda, but skilled nursing in general, especially in these pandemic days, has been very, very challenging. So we're working in the department and in the network on looking at ways to mitigate the impact of Laguna Honda's situation on flow in general throughout the network and definitely on ZSFG. So I'll be working very closely with Greg Wagner and Claire Horton, who's chairing that committee. There are definitely a variety of things we can do to address that. And then I think the other thing I just wanted to point out to you was the slide on page 21, which is that beautiful occupational health work status slide. And to say that COVID to some feels over, but it definitely is not over here at the hospital. Today we have 93 staff who are managed by occupational health services. This is across DPH, but it's mainly largely at ZSFG. 53 of these people are isolating. The rest of them are on a test to work status. That number has been going up. You can see it kind of starting to climb in this graph, but it's only gone up from there. So the way we're managing that, obviously we've got our very talented team in occupational health who receives these calls and manages them with the employees. We try to get them back to work as soon as and as safely as possible. But it's a big deal. And as you know, COVID is somewhat surging in our community. So we're watching this very carefully. We're reminding our staff about masking, especially indoors. We we don't want people to be in break rooms with masks off, eating with one another. So at least in the hospital environment, we're still very vigilant about that. So just to say that's still a big impact on our workforce. And I think there I'll stop and see what other questions you have or anything else I can clarify.
Thank you so much for the report. Is there any public comment?
Person on the line, if you'd like to make comment on item 5, please press *3 now. *3. I don't see any hand, commissioners.
Great. Commissioner Chung, any questions or comments?
Not at this point. Actually, I do have one. I shared your frustrations as somebody who tested positive last week for COVID. I know that, like sometimes, all these things are just not in our control. And I couldn't even figure out where I got it because like nobody else that I've been with, had tested positive. So yeah, I just want to express, like my empathy, that, frustrations about, like the staffing issues.
Thank you. And I hope you're feeling well and better after your diagnosis.
And thank you for all the detail answering the questions, Dr. Ehrlich. I really appreciate it. And, I think I share your concerns about staffing and how it's becoming, because, in my own office, we have so many patients that we interact with every week being an OBGYN. And I feel like sometimes we're like the wastewater or something where we get these reports, and it is really escalating from my perspective. I mean, a lot of pregnant women, of course, test themselves more often because they're concerned. But I got 4 calls this morning of people who are COVID positive, and many don't know where they got it. So had 3 delivering last week who were COVID positive. So I think, I'm not sure where it's going, but there is some concern, especially with the mask mandate having been removed, that we will maybe have to plan, not that people are going to be terribly sick, but that again, it's going to be a staffing issue. And we're seeing that at our place as well. So it'll be really interesting as we go through these weeks to see how this all shakes out and evolves. So let's see, I guess if there's no other questions or comments, we can go to the next agenda item. And my agenda just disappeared.
That is the HR, the hiring and vacancy report.
Right. Perfect.
Hi, good afternoon, Commissioner Green and everyone else on the call. Can you hear me okay? 'Cause I have my earphones in. I'm actually in bargaining. So can you hear
Can
me
you
okay?
speak up? But we can hear you, Karen, but it's pretty low. Can you speak a little higher than you normally would so we can get the volume up a little bit?
Yeah. How's that?
A little bit
Much
better. Thank you.
Better, yeah.
Okay, great. Okay, good afternoon, everyone. Karen Hill, Director of Staffing for Department of Public Health. I am here as the the director of staffing, but as well as filling in for Zuckerberg, as Carrie mentioned at the last month's report out, that she is now at Laguna as the interim operations manager, while our operations manager at Laguna has been placed as the interim labor relations director. So we have some musical chairs going around in HR and trying to fill in gaps as well. So I'm covering in those areas, as well as providing support to Laguna Honda right now, and as well as a participant in the RN bargaining team, which is where I am now, but reporting out for the JCC. So, Commissioner, you have the report in front of you, but you also had 2 questions as well, in addition to the report that you have in front of you. So before we go to the report, I'll answer your questions regarding the ED. The question was regarding the ED vacancies, the timeline to expect to fill the ED vacancies, as well as the training class that's currently going on for ED. So we have currently 10 vacancies in ED, as well as some double-digit vacancies in other specialty areas, as well as more vacancies across DPH for RNs. And so our plan was to expedite hiring, of course, for the double-digit vacancies in RNs, and have these positions filled by the end of June 30th, by the end of the fiscal year. And so what we have discussed, I had a brief discussion with Terry before she was deployed over to Laguna, as well as follow-up conversations with Jillian Otway, is that we're going to be hosting a RN hiring event at the end of May, close to the beginning of June, to fill a majority of the vacancies. We do have, we continue to have direct appointment authority. Again, being in RN bargaining, we want to try to address some of, a lot of the per diems, going into benefited positions. So we're going to be focusing on all the per diems that we have reached out to in the past couple of months, close to 500 per diems we reached out to. Almost 100 have expressed interest in benefited positions. So we want to direct our attention to those per diems first that are interested in benefited positions, and get them transitioned into these roles, as well as looking at the any new applicants that have applied, expressing interest, and get these benefited positions filled during this our RN hiring event. So we'll have more information regarding that hiring event for the next month's report out, and probably by the next month's report out, we'll have the date that we'll be looking to have that event scheduled. And like I said, we're looking at the end of May, beginning of June for that event. So more information to follow there. And as far as the training program for ED, we have a training program that just began a couple of weeks ago, April 7th. It was a 7 that was hired for the training program. It was 8, 1 declined, pretty much right before the training class began. And so these trainings, the 7 that were hired for training, they're already hired. And I know your question was, when will they be available to hire? So they are hired already into the training program. They go through 3 months of training before they go into the floor. So they're actually already hired into benefited positions, and they're going through their 3-month training. And so after that training is concluded, then we have another cohort that will be hired, which is 8. So we are committed to hiring 8 into the training program every 3 months. Around every 3 to 4 months, so every quarter. So that's our commitment for ED. And so that's where we are now for the ED. And for your second question was regarding the behavioral health, the mental health, behavioral health, and are we expect to hire, the 40 to 50 hires for behavioral health? So we did reach our goal, which was reported out at the Health Commission meeting last month, of 204. However, we still have an outstanding 100 vacancies to fill, but these are new positions. So these were not from the existing positions that we were targeted to fill by the end of March. So the 100 that we currently have right now, we are now in discussion on a timeline. We have to still work with the hiring managers. Hillary to establish a hiring timeline and a hiring plan and prioritize those 100 positions. So we'll have more updates about that timeline, hopefully maybe by next month. And so I'll make sure that's on a list of items to respond to you next month about the timeline. We're looking to hire those remaining 100 mental health positions. So those were only the 2 questions that you had for HR. And so directing our attention to the report, if you have any questions from the report that I provided, I'm open to provide any responses to those questions.
Well, first of all, thank you for all this detail. It's really very helpful. And I guess first I'll ask if there's any public comment on this item.
Thank you. Person on the line, if you'd like to make comment on the HR report, which is item 6, please press *3. *3.
All right. Any questions or comments, Commissioner Chung?
I have none. Thank you.
Okay. I just have I mean, it sounds really like you've done some wonderful planning for the emergency room, which is so critical to the other items we've talked about. And thank you also for this detail in the context of what has to be some very intense work you're doing now with negotiations and all of the issues with Laguna Honda and the changing positions of individuals. Do you have any well, 2 questions. First of all, how many hours do nurses have to work to be benefited?
Anything over 20 hours of
Over 20.
20 hours provides benefit. And so all of our benefited positions, all of our 2320 positions are benefited positions. We don't have any non-benefited 2320. So only our per diems are non-benefited, if that makes sense to you.
Is 20 hours and then your benefited industry standard? I mean, do they do that at other institutions, or is ours particularly generous in that area?
Well, I know for city and county of San Francisco, part-time employees, 20 hours or more are benefited. I believe if it's state requirement or federal requirement, any employers that hire either 50 or more, some are 100 and 500 or more employees must provide benefits for 20 hours or more.
Yeah, okay. And then, do you have any concerns about filling out these 100 new positions in the behavioral health area just because we've already hired so many and, there's a certain supply and demand where, are there other people out there, or do you have concerns? Because it's been so remarkable. I mean, every report, there's 50 more, 50 more, 50 more, but are there concerns about actually available individuals to fill the residual positions?
Well, for the most part, we've been having, a pretty viable applicant pool for the most part. I know in the area that we have our biggest challenge is behavioral social workers. And so that's been a challenge for us. But I have, out of the 100 positions that we need to fill, I have not seen the makeup of those 100 positions. So I don't really know what the challenges will be with those applicant pools, but we're hoping that, if they're similar to what we just hired the past couple of months, we should be in pretty good condition.
Oh, that's excellent news. Yeah, thank you so much. Any other comments, questions? All right. Well, then I guess we go to the next item on my once again missing on my massive
That's
desk
okay.
agenda.
It's the medical staff report with Dr. Winston.
Great.
Hello, Commissioner Green and Commissioner Chung. I am delighted to be able to present the medical staff report to you today. And I'm particularly pleased, with all of the challenges that we are facing, that my report today will be particularly positive. So the first thing I'm just going to highlight, we do not have a service report this month. So we're going to highlight a couple of things that happened at our medical executive committee meeting in April. So the first one, just for your information, one of our renowned physicians, Dr. Kirsten Bibbins Domingo, a long-standing member of our medical staff and a provider in our Division of General Internal Medicine in our primary care clinic, and a former chair of the U.S. Preventative Health Services Task Force, was named as the next editor-in-chief for JAMA, the Journal of the American Medical Association, and the JAMA Network, which is really wonderful. She is very committed to equity across all facets of medicine, including in publishing. And we are just thrilled for her, and also that she is it's just I think a testament to some of the amazing folks that we have here. So we just wanted to let you know about that. One other thing that happened at the Medical Executive Committee meeting in April that was also really wonderful is we got to hear from our 3 physician fellows in the Kaizen Promotion Office, or KPO. And just very briefly to let you know what they talked about. So Dr. Anna Chodos is in general internal medicine, and she is a geriatrician. And she is working on building a data-driven, age-friendly health system on the ambulatory side, and using some of the resources in the Kaizen Promotion Office to help her with that. Dr. Toph Peabody is from the Department of Emergency Medicine, and he is improving a performance improvement tool that's open to everyone in the emergency department, and also developing an emergency department equity and operational task force dashboard. And then finally, Dr. Lucas Zier, who is a cardiologist, is working with complex data analytics in the EMR to help to predict and then improve outcomes for patients with heart failure. So that was just really inspiring to hear about the work that they're doing. It was very well received, and so we just wanted to share that with you. And the only thing that I have on the action list is also really positive. So we have a new privilege that is in the Department of Medicine, in the division, in our pulmonary and critical care division. And that is that there is a new privilege in allergy and immunology that the division brought to the Credentials Committee and then to MEC. And just as a brief background, at the moment, we do not have allergy and immunology services on campus. Our patients are referred to UCSF through the tertiary care contract for certain services in the outpatient setting. And UCSF has very generously been available to us, through phone calls for, questions when, things come up in the inpatient service. But it looks like that we're going to be able to, hopefully, this is not a done deal, but hopefully be able to have somebody over here on campus who may be able to provide services over here. And so in preparation for that, the division has prepared a privilege so we can go ahead and get that person credentialed when that gets sorted out. So that is there for your approval if you, as long as you don't have any questions about it.
Wonderful. What a wonderful report and wonderful news. Although, will Dr. Bivens Domingo be full-time at JAMA, so we've lost her?
She will be largely full-time at JAMA, but I'm not 100% sure what her plans are for maintaining ties with us. We have had many people who, even though they have gone on to other positions, have been able to maintain ties with us, so I'm not certain.
Well, it would be wonderful if she would. And I know some people like Alice Chen will work a clinic every now and again, and they're such inspirational people, as you've said. How wonderful to have them at any involvement with the institution. They're wonderful teachers and as are your fellows. So this is great. Did I need to ask for public comment on this item?
Yes, please. Folks on the line, if you'd like to make comment on item 7, the medical staff report, please press *3. *3. No hands.
All right, then I guess we would entertain a motion to approve the allergy and immunology privileges, which is really wonderful news. Is there a motion to approve?
So moved.
And I will second it.
Thank you. Well, those, because there's only 2 of you, that's all we need for the action. And we can move on to item 8, the other business.
All right. Is
Thank
there
you, Dr. Winston.
any other business from the attendees or the public?
Folks on the line, if you'd like to make comment on item 8, other business, please do so now by pressing *3. All right, no hands for that. We can move on to public comment, item 9. Again, folks on the line, if you'd like to make comment about something that's not on the agenda, a topic that's not on the agenda, please press *3. No hands there. So we are now at a consideration for a closed session. Again, we'll go to the public. Any comment from you all on this? Press *3. No hands, so we're back to you, commissioners.
All right. Is there a motion to go into closed session?
So moved.
Second.
Great. All right, give me 30 seconds to go. And not everybody who's in the open session will join us. So thank you all. Those of you who aren't going to be joining us, thank you for coming today. And everybody else, give me a second to switch us over. We are back into open session, and I think everyone might be muted. That's what happens when we switch back and forth. Commissioners, please now consider a vote to disclose or not disclose discussions held in closed session.
Motion not to disclose the discussions during closed sessions.
Second.
So that passes. And now, unless there are other comments or questions, you all can consider a vote to adjourn the meeting.
Motion to adjourn.
Second.
Great. Thank you, everyone, so much.
Thank you, everyone.
Everyone, have a good night.
Thank you.
Thank you.
Thank you again, Commissioner Chung, for attending.
Thank you.
Thanks for your great questions.
Thank you.